Hospital. I'm going to present today about the basics of neonatal pulmonary graphics. Just a minute. Okay. Can you hear me first? My sound is clear? My sound is clear? Can you hear me? Shukran. طيب. Second, my presentation is clear. Can you see my slide? Can you see my slides?
I can see.
Yes, I have shared. Is it clear?
لا ادخل على الميتنج وصور فوق شير. في هذا الميتنج مهم جدا. تروح على النقاط الثلاثة.
Can you see my screen now?
دوس عليه ويكليك على الويندو هذا على الصورة نفسها. كليك على الويندو بعدين شنو؟ خلاص خلاص يا دكتور. I can see it now.
بسم الله الرحمن الرحيم. Okay. I'm going to present today about the basics of neonatal pulmonary graphics. Okay. So we are in pulmonary graphics. We are talking about waves and loops. So the waves, when you are talking about three parameters, either pressure, flow, or volume against time. So it's like waves. Okay. The loops, which is coming from zero and going back to zero. So it's loopy. And we are talking mainly the pressure volume loop or the flow volume loop. What is the importance of graphics? So it is the in the NICU, as you all know, that it is the art of trending. So you need to check your all surroundings, not just the baby himself, to examine the baby himself. You need to take a lot of input from the nurses, from the infusion pumps, from the monitors. And one of them is, of course, the ventilation. So the ventilation, the issue that what we used to do before is just put the baby on the ventilator and depend on the blood gas and X-ray. But nowadays, you can't see the interaction between the machine and the baby. And this is really helps a lot in doing the proper function, to check the proper function of the ventilator. Is it functioning well? If there's any troubleshoot, of course, it will help to in determining what is the patient's disease status, how is the lung compliance, how is the airway resistance, and of course, it helps for fine-tuning of the ventilator. So if it helps to decrease the work of breath, maximize the patient comfort, and it helps to optimize the ventilation. And of course, it helps to check the response to therapy. And the best example of that, when you get, especially in pediatric age group, if the patient is asthmatic and you give him nebulizer, when there is a bronchospasm, you can see a really good response when the airway is opened nicely. So if you are talking about the lung compliance and the airway resistance, so just to give an example to understand that, so if you got a balloon, you have an old balloon and a new balloon. So when you are trying to inflate the old balloon, you are so the bulb of the balloon is we can say that this is the compliance. So the bulb, and the neck is the airway. So if you have a new balloon, it is still a fresh balloon, it is a stiff balloon. So you are trying to generate a high pressure to start the flow, to generate volume, to inflate the balloon. So you need very high pressure to open. So if you compare this a new balloon with old balloon, it will be very elastic, very easy to inflate it. So the old balloon is the normal lung, and the new balloon is the stiff, just a fresh preterm baby with RDS, which is with very bad lung compliance. So the best example of the compliance when you are talking about respiratory distress syndrome in neonates, especially in preterm babies, due to surfactant deficiency. And the airway resistance, when you are talking about as we said now, the neck of the balloon, if it is, of course, if it is wide neck, it is very easy to inflate it. If it is very narrow neck, it has very high resistance. So you need also high pressure to generate flow. So this is the best way of that. If you have in the NICU, if you have, of course, airway obstruction, but which happens usually with meconium aspiration syndrome due to a lot of secretions and, of course, meconium obstructing the airway. So moving forward, so again, if you need to understand the pulmonary graphics, you need to understand how the ventilator works. So the air and the oxygen is coming from the wall, it's coming to the reservoir. So here you can get your FiO2, and this is, you have a continuous flow. The old models we used to control, the old models of the ventilators, you need to control, like baby log 8000, the old models, you need to control the flow. Nowadays it is automatically done. So the flow of air is coming to the patient, to the tubings, passed to the humidifier. So there is a continuous flow of air in the tubings. Now, the job of the ventilator is to generate pressure. So again, the job of the ventilator is to generate pressure. According to the setup, then what you put as a setup, then it will, this pressure will be translated as volume guarantee, or how much numbers you want to get it. But the job, just to keep in mind, so the job of the ventilator is to generate pressure. So this air coming in the tubings, so here it goes to the humidifier, then to the inspiratory lamp, then to the patient, and from the patient back to the expiratory lamp, and nearby the ventilator. This is the exhalation valve, which is a one-way valve, and there is a valve also for the PEEP. So you set the PEEP, there will be continuous pressure, and when there is a PIP, the exhalation valve will close, so the ventilator will generate pressure in the tubings. This pressure will be transmitted to the patient to inflate the lung. Now, here nearby the ET tube, you have the flow sensor. So the flow sensor measuring the air going in and out. So through the flow sensor, you measure flow against time, you get the volume. So here you know how much volume is going in and out, and from the flow sensor, you get the flow graph. So here to understand it again, so the job of the ventilator is to generate pressure. The flow sensor is to check the flow, and with the time you check the volume. Again, the basics of the ventilator. So you need to understand that the respiratory cycle, it will start by a trigger. So this is the trigger of the respiratory cycle. It can be triggered by the patient, or it can be controlled by the machine. So when it is, of course, this is according to the mode you are keeping from the beginning. So is it really continuous mandatory ventilation, CMV, which usually we use it for paralytic, paralyzed patients, or you keep them, we are not using them in the NICU, usually those in adult patients. So here, so it is fully controlled by the machine, and there is no rule of the patient. Now in assisted there will be starting by, so the machine will wait for the baby's trigger, then it will start to trigger the ventilation, and this trigger usually from the flow sensor. What we are using in the NICU, just as you all know, we are using always pressure control modes in the neonatal patients, and we are using a flow trigger. Now somebody will ask me, why flow, not pressure? Because those tiny preterm babies, they don't have that much really high negative pressure, so we can give it, or the ventilator can read it through the flow sensor. So we use the flow sensor because we can read very minimal flows as initiation from the baby to trigger the breathe. The only problem, of course, here when you have when it is sensing very minute flows, this can be auto triggers, so it can cause an auto trigger to the ventilator because it is easy to be triggered. We'll talk about it soon in the slides. So the start of the cycle by the trigger, then you need to reach your target. As we said, we are usually in the NICU, we are pressure modes, so we are pressure targeted. Then in the pediatric and adult patient, we can use the volume. So the ventilator will increase the pressure till you reach a target, which is this point. Then you keep a plateau. This plateau, the importance of plateau is to give time for the alveoli to be recruited, to open up the alveoli. So, and this time, of course, here explained by the inspiratory time, I time, it helps, of course, to get time for the gas exchange. Then, when the inspiration is about to finish, there will be what we call the cycling. So the cycling here means this can be time or can be flow. We will come to it now. So again, so the inspiratory cycle will start by the trigger. Then, of course, there is a rise time. This one, this is the time you need to reach the target. Is it short? Is it slow? And this is, of course, determined. Here we are doing it manually. Before, you need to play with the flow to get this rise time. Now you get it as a number, and you reach then the target, and you need to keep it in plateau for the inspiratory time till you reach the cycle, means the time to stop, the time to open the exhalation valve. So the expiration will happen. Then you can go to inspiratory time, then again to go for another cycle, and so on. So this is the types of breathe. We said it is either controlled or assist. So assist, there will be some negative pressure, if this pressure trigger, or flow trigger, which we use in the neonate. So assisted, and then it will start. In our ventilator, you will see like a small lung, means that this is triggered by the baby. The rise time, as we said, this is from the trigger till the target. So here what we need is the moderate rise time. So it will go smoothly till you reach, and you get good plateau before the exhalation, before the stopping the cycling of the ventilator. So if you have slow rise time, so then you don't have time for the plateau, then you don't have time to recruit the lung, you don't have time for gas exchange. We don't want that. And if you have a very very rapid rise time, so again, this will cause pressure overshoots, which can cause lung injury. So you don't want that. And this is, you can see the pressure overshoot by this one means that you have very rapid rise time. So this is what you aim for. Again, this is what you want, good eye time, not this one, which means that you don't have enough time. And see how this can be explained. So if you have enough rise time, you have time for inspiration till the flow comes down for the inspiratory time. But here, see, the inspiratory time, you don't have that much time even. Even so, the lung is not recruited, and still it is very short eye time compared to this one. We'll come to this explanation. Again, another important concept. Now, how to measure this eye time? Now, we mentioned that to have a proper lung recruitment, alveolar recruitment, you need a good eye time. But how to determine this eye time? We used to do it before, like just 0.3, 0.35, but there is a calculation for that. So to reach the full eye time, you need actually 5 time constant. But by this graph, 98% of the eye time, you reach it in 3 time constant. So what is time constant? Time constant is the compliance, product of compliance multiplied by resistance. So as we said, the lung compliance and the airway resistance. And this is the way of calculation. This can be calculated with the new ventilators. So the compliance multiplied by resistance multiplied by 3, you get a 3 time constant, which is the eye time. Now we don't need to calculate it; you just see it in the graph, and as we will describe now, and you will know that this is enough eye time or really short or long eye time. So again, for the cycling, which means the stopping, we said there are 2 types. Is it time? Cycling means the time you open the exhalation valve and to stop the inspiration and start to the expiration. This is called cycling. So is it time or flow? Now, the time in all the other modes of ventilator, in flow cycling, only in the pressure support ventilation. So in PSV mode, you will use the flow cycling. In a way, you give the baby or the patient the control when to stop the breathing. And how, of course, this is indirect way because it is determined actually by the lung condition of the baby. So if the lung condition or the compliance is okay, then the baby himself, he can control. So how the machine works with that? So the initial flow to generate the pressure to reach your target. So this is the peak inspiratory flow. Then with the dropping, the machine, now the triggers is auto-cycled. Auto means the automated to stop at 20% of the flow. So by when it reach the 20% of the flow from here, so when it is reaching the remaining 20%, it will open the cycle. So this is the way it works. So here, just keep in mind. So if the flow is not reaching 0, and you put PSV, this means that we are doing a flow cycling. So this is not a short eye time. No, this is you have put it from the beginning in the settings. So the breathe ends when the ventilator detects the inspiratory flow had dropped to a specific flow value. Now, the other ventilators, you can play with this pressure support or the flow cycling percentage. So again here, the problem if you have the flow cycling, if it is very high or it is very low. So if it is very low, the patient wants to exhale, but you don't still allow. You didn't open yet the expiratory valve. So you have exhalation spike. So if you have exhalation spike and you are in pressure, yeah.
The spike means active exhalation.
Active exhalation, and still you are not opening the valve, so you will see it as exhalation spike. Okay, this means that you are having very low flow cycling, and of course, as we said, this is not in our ventilator. And if it is very high, again here you don't have enough eye time. Again, the same problem, you don't have enough time for recruitment, you don't have enough time for gas exchange. There is very important point here just to remember that if you have too much leak, and this leak more than the flow cycling, so whatever you put as, you open up the eye time, the patient will receive it. So let us say, usually when you put from conventional ventilation, you change to PSV, you have to increase the eye time. You have to give more eye time for the baby himself to choose whatever he wants. Now the problem, if you have leak, the machine will keep opening till the end. You keep it. So the baby himself, he will suffer. So the flow cycling will not work properly if there is very high leak. This is just to keep in mind. Okay, so now the description of the wave form. So there is a pressure, flow, and volume against the time. So the pressure wave will start by the PEEP, the trigger for the PIP, till you reach the target, your maximum PIP, whatever you want. Then this is the time of cycling, stopping the ventilation, opening the expiratory valve, expiration, and then it will go to PEEP again. So this is yes, the plateau here. Then the flow, you need to start by 0 and go back to 0. And this is the inspiration, and this is the exhalation. Again, it should start by 0, go back to 0. So the area under the curve here is the tidal volume. Is the tidal volume. So this tidal volume in the inspiration should equal the area under the curve in the expiration. So the tidal volume in inspiration equals to expiration. If it's not equal, this is a leak. Okay? And then the volume curve. So it starts again by 0 and go down to 0. If it's not reaching 0, it is what we call shouldering. If it's not reaching 0, here this is a leak. We'll come back to this to the description. So the pressure waveform is again the same. Now, what is the importance of this waveform is to understand that the area under the curve in the pressure time waveform, the pressure time waveform is the area under the curve here is the map. So the main airway pressure is the area under the curve. So here to understand that, so if you want to increase the map, as you all know, for the lung recruitment, you need to increase the map to increase the oxygenation, to improve the oxygenation. So to increase the area under the curve means to increase the map. So here, very easy. So either you increase the rise time, make it more steep, more sharp, or increase the PIP, or increase the inspiratory time, or increase the PEEP, or make it rapid breathing. So all of this. But from this graph, you understand, from this drawing, you understand that to increase the map these are the factors that can help to increase the map. So the most important, of course, we are using either by increasing the PEEP, which has a biggest effect, increasing the eye time, increasing the PIP, and little bit on the rise time or the higher rate. Now in the flow wave form, the importance, as we said, you know, the peak inspiration and the peak expiration, you know, the inspiratory time and expiratory time. It should start by 0, end by 0 in the inspiration, and start by 0, end by 0 in expiration. Okay, so the above the baseline is inspiration, below the baseline is expiration. So it is important to know that if there is leak, so this is the eye time. If it is either it is not enough or there is leak, it's helpful here. If it is not reaching, there is air trapping. If there is obstruction, and as we said, the area under the curve here is equal to the volume. And the volume flow wave form. So it is half of it is the inspiration, and the other half is expiration. And there to have a good eye time, there will be some curving. Means when you have a good eye time, so you have time for the inspiration should be curved in this way, and for the expiration again to reach 0 should curve. If it's not reaching 0, this is leak, as we are going to come now. Now the pressure volume loop. The pressure volume loop, it should start from the PEEP here. This is the pressure. You should start from the PEEP. Of course, as a volume starts from 0. So you start by inspiration till you reach the PIP, and here what we call the critical opening pressure. So here you give pressure, increase, and still there is no volume. Still, you didn't inflate the lung. Till a time you start to open, so little bit of pressure will generate large volume. So this is called the critical opening pressure. So you need to increase the pressure till you reach this critical opening pressure. Now, if this is taking very long time here, if it is taking very long time, so to overcome this very long critical opening pressure, you just increase the PEEP. So you increase the PEEP, then the whole thing will improve. The critical opening pressure will improve. So we'll go up till you reach the PIP. Then when the pressure will go down, again, still the lung is still inflated till you reach, this is the critical closing pressure. So there will be a little bit of change in the pressure with rapid drop in the volume. So this is the critical closing pressure. So this is the critical opening. This is the critical closing. So this slope here is representing the compliance. So the compliance, the more to the left is better the compliance. What does it mean? It means that less pressure to generate more volume. So better compliance. If it is going to the right side, shift to the right, means bad compliance. So very high pressure to generate less volume. And the what we call it, the hysteresis, means the width between the compliance and the loop itself, this is representing the resistance. So the high the resistance, so either in the inspiration or expiration, the wider the loop, which you should not have it actually. Again, so here when you have a trigger, so it will be a bit like a spike or a tilt like that. So it will start again and go back. And you go back to your PEEP. Now, if it is dropping so fast, it's not reaching 0 here, this means that there is leak. And as we said here, this is the pressure required for alveolar recruitment. So this is the critical opening pressure, you can see, because here you have very high pressure, then at certain point, less pressure difference, very high volume. So this is the critical opening. And here again, you drop with the pressure till you reach the critical closing pressure. So sharp drop. So you want to ventilate the baby in this area. So the importance of the pressure volume loop, it helps to understand if there's overdistension, if there's airway obstruction, the response bronchodilator, respiratory mechanics, work of breath, if there is a flow starvation, leaks, and triggering efforts. So we'll come to it for those benefits. Now the flow volume loop. So in the upper portion, this is the inspiration, and the lower portion is expiration. So it's like the pulmonary function test. We are sending the baby to do the pulmonary function test. It's like the inversion. In pulmonary function test in this way. Here in the graphics, you start from the inspiration from 0. Then expiration will start, and this is the peak expiratory flow. Then we'll go back to 0. So again, this is the area under the curve, is representing the volume. Now, what we have described as benefits, you will get to know it now. So as we said here, if you have, this is the I time, as we said, it should start by 0 from the flow time waveform. So it should reach 0. If not reaching 0, we said, is it a PSV mode? We are in a pressure support ventilation mode. This means that this is flow cycling. But if you are not putting the baby from the beginning on pressure support mode, so it can be, this means that it is either short I time, so you are not giving enough time. And as we said, if there is no enough time, means either you have high resistance, because we said the I time is 3 time constant, and the time constant equal to the compliance multiplied by resistance. So if there is high resistance due to secretions, due to kinking in the ET tube, due to displaced ET tube, this will cause high resistance, means that it will show up as short I time. It's not reaching 0. So this is one aspect. Or there is improvement in the compliance. Why? Because initially in the, let's give it as an example, in the RDS of the preterm, initially there will be small tidal volumes and the baby is breathing very fast. So he needs very small I time, 0.3, even sometimes 0.25. You don't need, it is very short I time. Now, when you get the surfactant, lung compliance improve, the lung will start to open up nicely. So then this means that you improve the compliance. This means that you need to increase the I time. So this is the importance, the beauty of the graphics. You know, so initially the baby was not in need for this I time. Now we need more. So if it is not reaching 0, it is short I time. We know now why. Or there is another point, is the leak. So again, because it is leaking, it's not reaching 0. Okay, so these are the 3 problems you may face it. Again, we mentioned when it is high compliance, improving in the RDS, or high resistance with the secretions. So this is very important according to the baby stage. Means if the baby is right now, he's RDS, you understand that you give the surfactant, you understand that he is really improving in the compliance. But a chronic patient, you come and you see the I time is not reaching 0. Is it? So either it is leak, and you check the leak from other place, we will talk about it right immediately, or there is a secretions, and again you will see it from another place that the nurses has to do suction. So again, here short I time is not reaching 0. So here again we said that it's not reaching 0. So if it is not a PSV mode, of ventilation. So either leak or short eye time. So short eye time, if we see, you go to the volume. If you see that the graph is not reaching to 0, it's shouldering, this means that there is leak. So here there is leak. This means that this is not short eye time. This is due to leak. That's why it's not reaching 0. So you don't need to play with the eye time here. Okay, so this is the leak around the ET tube. What else where you can see also the leak? From the pressure volume loop. So it should go, start by 0 and should reach 0. If it is sharp dropping like that, this is leak. Again here from the flow volume loop, again, it should start by 0 and should reach 0. If it cut here, means that it is leak. So there are many ways to find out how, if there's a leak around the ET tube. So the best place is the volume waveform. Again, the same. The same. Okay. Now, if the having an issue with the expiratory time. So the expiratory time, again, we said that it should reach 0. If it is not reaching 0, due to either high expiratory resistance, it is high expiratory resistance, so that's why it's not reaching 0. You need very high expiratory time. Of course, here means you need to do suction, or maybe the ET tube is kinked, or the ET tube is deep, going to carina, touching the carina. So this is, again, will cause high resistance. So, and this will cause what? If the expiratory time is not reaching 0, so the air which is trapped there, it will cause what we call it auto peep. So you can't see it in the measure. You put the peep on 6, but in the measures, you see peep of 7, peep of 8. So from where it comes? Because of short expiratory time. The problem here, when you have high inspiration, you put high inspiration time, you don't adjust it, or you put very high, very rapid breathing. So the baby is not having time to exhale. You need to reduce the respiratory rate. Otherwise, you will cause air trapping. Again, so the expiration should be sharp and should reach 0. If the expiration is not sharp like that and it's going very sloopy and it is not reaching 0, so this is air trapping causing auto peep. So here, from the flow volume loop, so here it is not reaching 0, and in this place means there is air trapping. Now, why there will be increase in inspiratory resistance? As we said, is it air obstruction in the large airway? Either there is obstruction with the secretions, there is a bronchospasm, or there is secretions. Okay, again, high expiratory resistance. Again, high expiratory resistance from the loops. So you need to check the graphs and the loops to understand what's going on. Okay, so when you have the expiratory time is not reaching 0, you need to check why it's not reaching 0. So most probably there is high expiratory resistance. Most probably there is secretions. So either it is bronchospasm, or kinked ET tube, or secretions. So again here, see, it's not reaching, it is a scooping, so there is very high resistance, so the flow is not coming out easily. There is a scooping out. And this is very nice when you, in case of bronchospasm in asthmatic patient, so when you give bronchodilator, so there will be improvement in the peak expiratory flow. So once you give the bronchodilator, there will be improvement, and it will be the peak and expiratory flow will be sharp, will be higher, and it will be reaching the exhalation, expiration easily to 0 without any problems. Again, so here normal, here when there is a bronchospasm, and this is after giving the bronchodilator. Here the hysteresis, again, if there is high resistance, and when it is both in the inspiratory and expiratory, this means that there's something happening in the ET tube. So most probably it is kinked, or in adult patient, it can be a patient biting the tube, or it is migrating, going down to the touching the carotid. Now in the compliance, so with the change in the compliance, as we said, it is when it is it's going to the shift to the right, means poor compliance. When you give the surfactant, there will be improvement in the compliance. Now here, this is the beauty of putting the VG. Here, the importance of putting the volume guarantee. Why? Because in preterm infants, once you give the surfactant, there will be improvement in the lung compliance. So if you didn't put VG, what will happen? So the lung, simple, the same pressure you are giving, it will give larger volume. But when you put the VG, there will be auto-weaning. So the baby himself, the lung itself, because there is improvement in the compliance. So, and you put the same volume guarantee. So the pressure with the time needed, it's improving. So there will be auto-weaning of the pressure needed. So the VG, again, so the volume guarantee, you need to understand the importance of volume guarantee is mainly for dynamic changes in the lung after therapy. So it is a very important, very nice for RDS, but it doesn't work, let us say, for a patient with chronic lung disease, because it is totally different. You have a totally different pathology with high resistance, a lot of secretion. So it doesn't work. The volume guarantee doesn't work with the chronic lung disease, but it works very nice with a patient with RDS. Again, here, so with the pressure volume loop, so here, if there is a peaking in the flow, this is related to the overdistension. So this is peaking. So when there is a peaking here, means that there is overdistension. And here, if the C20 to C dynamic, this one, so the last, the 20%, if it is like that, is more than 1, and this is, again, you can see it in the ventilator. If it is more than 1, this means that there is over distension. So again, please look to your readings in the monitor. So you don't want over distension. Instead of doing X-ray, this will help you a lot. Now, what is this? This is air hunger. So if you are giving the baby, putting the baby on SIMV, and you put him on rate 10, and mashallah, you put him on SIMV, you don't put PSV. So what will happen? The baby will breathe against the ET tube, as if you are suffocating the baby. So what will happen? The baby will have air hunger. He is not happy. So please, whenever you are putting SIMV, alhamdulillah, the new modes of ventilator is having a PSV mode. So the PSV, usually you put it half of your required PIP, or minimum 4 to 6 to overcome the ET tube resistance. At least you want to let the baby breathe, fine, but at least help him to overcome the ET tube. So how it will show? It will show like looping, like figure of 8. So this is the baby is breathing very fast, he's not happy. Or it can be inadequate flow. Now, anyway, alhamdulillah, the new ventilators, we don't have this issue anymore because it is auto-adjusted. Or inadequate sensitivity. So if you put him high trigger, so again, as if you are suffocating the baby, you are asking the baby to generate very high trigger, very high flow to trigger the ventilation. And the baby, again, he's doing the job himself against the ET tube. So please check for that to make sure that he is, to give him the easy trigger. Again, the same. Okay, now this is the problems we are facing. The nurses, of course, this is a daily talk about the auto triggering, auto cycling, and this is happening usually when there is condensation in the tubings. And frankly speaking, we were having a lot of issues when we got the new ventilators, and alhamdulillah, finally we could sort it out by understanding that the temperature sensor for the tubings, for the humidity, it should be outside the incubator. So if it is outside the incubator, it will be properly warming, heating the ET tube, so you don't have condensation. Why? If the condensation happens, what would cause? The water will move in the ET tube, and this will be sensed by the ventilation as if it is triggered. So it will cause auto-triggering. And the nurses can detect it easily. She will see the alarm. Of course, don't ignore the ventilation alarms, please. When there's an alarm in ventilator, this means that there's something. So the easy thing, very high respiratory rate. You put the alarm at 70, 80 rate, and you come and see rate 130, 140. So this is not from the baby, definitely. This is from auto-trigger. So the best example of it is if there is water condensation. There is another causes for that if there is leak. Leak, if it is high leak, when the air is coming out, it can be again sensed by the sensor as if there is auto-trigger. So this is another cause for auto-triggering. The third cause, if there is extubation, there will be again alarm, and this is moving fast, and this can be extubation. Okay, but here, very importantly, this is very important point. So if you have this, so the ventilator is alarming, and you have this auto cycling, and you come and check what is the PIP received, it will be very low. Where is it? I'll come back to it. Okay, so this is extubation. So these are the three causes of autocycling. It can be secretions, can be leak, or it can be total dislodgement of the ET tube. So this is turbulence. Turbulence means secretions or water in the ET tube. Okay. Again, turbulence, secretions. Again, see? So from the loops and the graphics, it gives you a lot of information. Okay. So pass this. This is very interesting. I have Sarah hear it in one of the conferences. So we know about DOP, displacement, obstruction, pneumothorax, and equipment. So if you have a baby who's having a sudden clinical deterioration, sudden dropping in the saturation, so you need to check for your DOP. Is it this tube displacement? It means extubation. Is it obstruction, pneumothorax, or equipment? How to know it from the graphics? We have just learned it now. So again, why I came back to this diagram, again to emphasize that the job of the ventilator is to generate pressure. Thank you. So if you are not able to generate, if the machine is not able to reach this pressure, what does it mean? So the machine is pressurizing and this pressure is not reaching. This means that the ET tube is out.
Yes.
It's not connected to the baby. It's a simple way. So initially when you have, again, so from the beginning, you have sudden descent, it checks the pressure. Is it achieving the target? When you put, like I put it, PIP 20. When you come, again, as we said, you need to check the measures. So the measures, you see the pressure is only 5. How come? I'm putting pressure 20 and it's not reaching. So this is the best example of tube displacement. So this is D. Okay, so this is the first one. From the pressure waveform.
Yes.
Then, the pressure is okay. You come to the flow. If there is auto-triggering, this means that it is?
Again, this is, the tube is not in place.
Yes. Again, so it is displacement.
Yes.
Yeah. Sorry, again. So we just to make it again, because here myself I confused you. So again, so we said that the ventilator job is to generate pressure, and the flow sensor is checking the flow which is going to the patient. So if there's a problem with the pressure, this means that the problem in the tubings before the flow sensor. The problem will be in the tubing. So this connection usually will be around the humidifier. Okay? But if you don't have a problem with the pressure, you go to the flow. If you have a problem with the flow, so this is after the flow sensor. So this means that there is ET tube displacement. So this is the difference. Again here, so I confused you, sorry. So you check the pressure waveform. If you are not achieving the target, this is equipment. Equipment means there is this connection of the tubings before the flow sensor. And usually you will see that nearby the humidifier. You will see that the sensor is out, the tube is disconnected. So this is happening before the flow sensor, if you are not reaching the pressure. So this is E. This is E. If you have a problem with the flow, means after the flow sensor. So this is ET tube, extubation. So this is displacement. So this is displacement. This is equipment. Now, again, in the flow wave. If the flow wave, if it is very small wave, means that there is very poor compliance. So why a patient who was normal lung compliance and suddenly very small compliance? This means that in pneumothorax, something compressing the lung, and you have only small lung volume, so you have a small flow wave, which was initially larger flow. Okay? And or if there is very high resistance, it will be short I time. So not the size of the flow, it is the I time. Why is not reaching? It was reaching normally. Why is not reaching now? This means that there is either kinked ET tube or secretions, obstruction. Okay? So this is clear. So this is, if you are not reaching the pressure, this is E, equipment. If you are having auto-triggering, so we'll see here. So auto-triggering, okay? If you have auto-triggering, means that the ET tube is out. So continuous flow. This means that the tube is out. Extubation. If there is a small flows, which was before large flow, why now is very slow? This is decreased compliance. Acutely means pneumothorax. Or if you have turbulence with not enough I time, not enough E time, this means secretions or obstruction. Thank you so much. Any questions?
Thank you very much. Amazing, Dr. Dana. Right.
The floor is open for the discussion. If there is any question for Dr. Ahmed, because we are running out of time.
Hi, good morning. It's me, Khalid here. I'm not sure if my voice is clear or not, but I want to make a comment. That's okay.
Yes, please, go ahead.
Thank you. It's a very elegant, and as always, we never get enough of this pulmonary graphics and ventilator graphics. All the time there will be something new, and it's very refreshing. So thank you for that. I just
Thank you.
to said about utilizing the ventilator and the screen to troubleshoot when you have deteriorating baby. One of the things that I found most of the time is people straight away, when there is a little bit of desaturation, or they disconnect the baby from the ventilator and they start to bag or provide IPPVs or TVs. And then you lose a very valuable source of information as a problem of the baby. So if the baby is not crashing, you could do anything through the ventilator while the baby is connected, and you can reach a big diagnosis. So if you reach a diagnosis, then yes, you can move on and you can provide whatever the baby needs. Just try to get that information from the ventilator first about what you just mentioned. Is it up to you? Is it dislodged? The machine itself. So try to get this graphics, try to look at the waveform and try to reach a diagnosis. Because when you come into the baby and you don't know what's going on, sometimes you could do a little bit more harm than benefit because you lost that important information. So whoever was attending the baby, try to get that information. What was the ventilator showing? If the people need to disconnect the baby from the ventilator. Thank you.
Totally agree, totally agree. And this is, as we said, it is an adding value. The graphics is adding value. So it is not substituting your clinical sense. You need to disconnect, you need to try bagging, you need to check the air entry, you need to throw the trans illumination, do chest X-ray. But this is really an adding value to what you are doing in your clinical practice, watching your surrounding and see what's going on. Yes, yes, yes. Thank you so much. I think we can finish now, conclude. Thank you so much.
Thank you very much.
Thanks so much.
Thank you, everyone. Thank you for the organizer.
Thank you.
Next week, inshallah, virtually.
Assalamu alaikum.
مع السلامة.
Happy to all of you. Enjoy your meal.
Thank you.